Hi, everyone. Welcome to our FMEC annual meeting seminar sampler. Today, we'll be talking about the 5 myths of the Against Medical Advice AMA hospital discharge. I'm Dr. Tracy Conti, the chair of family medicine at the University of Pittsburgh School of Medicine and a board member of the FMEC. So just a little bit about the FMEC, we really consider ourselves a catalyst, convener, and incubator working in 14 states plus DC in the Northeast US. We serve about 60 medical school departments of family medicine and about 200 family medicine residency programs. Our goal is really to promote family medicine and primary care to medical students. We support our residents as they transition into their careers and really try to strengthen academic family medicine by creating and sustaining quality improvement initiatives and stimulating innovative approaches to primary care delivery, much like we're going to hear about today. We always like to take the opportunity to remind you of our annual conference. This year, it is being held in Rhode Island, October 13th through 15th. So please look that up and save the date on your calendars. So today's speaker, I'd like to welcome Dr. Tim Pelkowski, who is with Allegheny Health Network at St. Vincent Hospital. Dr. Pelkowski, I will turn it over to you.
Thank you, Dr. Conti. Let me just take a moment here to share my screen. All right. Okay. Thanks for that introduction, Dr. Conti. I appreciate that. Certainly thanks to Scott Allen and Denise Steele for helping me get this arranged. I really am looking forward to this and enjoy and appreciate being asked. I'm currently the program director up here at the program in Erie, Pennsylvania. And my topic today is the 5 myths of the Against Medical Advice Discharge. So as I start to go through this, I did want to put a plug out for the other virtual seminar samplers that are coming up through FMEC. I think this is a wonderful idea for some lunch and learn. So make sure you check the schedule for the upcoming episodes well after mine. As far as disclosure, I really have nothing from a financial standpoint. And given the nature of this talk, there's no unapproved or investigational issues or products or devices that we're going to talk about. And just a picture of our Bayfront area here in Erie, Pennsylvania. I will set the stage here by saying that these slides are very busy. Don't let them distract you. I know our eye is drawn to read every word on the slide, but don't worry about it. I'll go through everything. We sort of use this as an enduring reference in our residency program, so that's why we've done this. And the material is very repetitive. I'm not trying to insult anyone, but I'm trying to do this on purpose. We really just want to make sure that we bring home the concepts for this. So like I said, busy slides, repetitive issues, don't let that throw you for a loop. Don't let it distract you. Now, probably some of the key questions that we're going to try to answer as we go through this lecture today are 5 key areas. And bear with me as I go through this. The first one is when a patient is declining the recommendation to stay hospitalized, that we have to discharge them AMA. And I want you to think about a yes or no answer to that question. If we do an AMA discharge, we have to use the forms that our institution recommends for us to use. Again, yes or no. The use of these forms will decrease legal liability for a patient who's leaving the hospital AMA. Again, yes or no. And that physicians really aren't obligated to provide other treatments or services if the patient does elect to leave the hospital AMA. And then finally, most medical insurance plans will charge a patient more if their discharge is deemed AMA. And again, think of that yes or no. And my hope is that we'll go through and answer all of these by the completion of this lecture today. As far as learning objectives, my goal is first to review the definition and characteristics of the Against Medical Advice Discharge or AMA discharge. So we're going to really look at the epidemiology, if you will, of this. We're going to then highlight the 5 most common myths associated with AMA discharge. And then we're going to talk about some tools that we can use for our learners on how to tackle this, some universal precautions, some basic models to follow. These are not rocket science, but I think it can be helpful for a medical student or a resident to have a framework on how to tackle this. And really that's going to lead into our final learning objective, which is just having some sort of a standardized process for the AMA discharge. I think before I prepared for this lecture, it was a much more helter-skelter and anxiety-provoking process for me. And my hope is that when we get to the completion of this, that this won't be your path when it comes to an AMA discharge. And I'm not going to go through all of these, but typically when I've got a live audience, we'll hit some of these questions. And I really just highlighted the first one that I wanted to go through, and that is whether or not anyone here has had education formally on the AMA discharge, whether in residency or in medical school. And I have to tell you, to date, when I have posed this question, I'm really not getting any kind of formal education around this. So because of that, I think this is an important topic for us to address. And I think furthermore, there's a lot of misinformation around this, and those 5 myths in particular we're going to hit. And when I think of the 4 horsemen of the apocalypse, I think we can add the 5th one being misinformation. And of course, COVID has probably highlighted what misinformation can do. So let's break down our agenda here. The first thing we're going to do is go through the epidemiology, if you will, around AMA discharge. We're then going to hit those 5 myths that we've talked about already. We're going to go through some of these models that we can have our learners use when they're tackling these kinds of discharges. And that's going to be the ask, tell, ask model. We're going to talk about universal precautions as well. We're going to spend a little bit of time on appropriate documentation for an AMA discharge. And then I've got a couple of very basic examples just to highlight and illustrate some points. And then we'll wrap up with just a quick summary of what we covered. So as we start to dive into the epidemiology, if you will, the AMA discharge is typically regarded as when the patient leaves the hospital before reaching a physician-recommended endpoint. However, I would stress there's no formal definition. This is just one thing that's been put out in the literature. I'm going to offer another definition in a moment. So be aware of that. There's really no good formal definition around this. It's somewhat common, right? 1 to 2% of hospital discharges will have this occur in the US, and that's about 500,000 times per year. I'm sure any of us with a few years of experience under our belt have had to deal with an AMA discharge. And it's probably not surprising, but those who are discharged AMA have increased 30-day hospital readmission rates up to 20 to 40% higher than a standard discharge, but also increased mortality rates. And some of the literature has shown even as high as 10% increase compared to the baseline population. Carving out some of this information, I did look at one study from Boca Raton Regional Hospital in Florida, and they looked at just about 550 AMA discharges. And that was out of a total of over 350,000 discharges over the year of 2020. They didn't really feel that the pandemic made a significant impact on this study, but here's some of the data we got. 60% of AMA discharges in that were men. The mean age was 56 years old, actually a little bit older than I might have thought. The average stay before this AMA discharge occurred was just over 1.5 days in particular. And very importantly, in a third of these cases, there was really no documented reason for this AMA departure, if you will. And I think that's something at the very least that we should try to correct here. When they tried to parcel out what the factors were for when they could determine on why the patient was leaving AMA, about 20% or a fifth of these were sort of hospital-related factors, and just under half were patient-related factors. And as we break that down a little bit, some of the hospital-related reasons I don't think are surprising to us, but it's primarily around wait times, hospital environment, wanting a private room. Some of these are things that may be outside our control. Patient-related factors are certainly a big part of this as well. Refusing treatment is certainly up there. But addiction problems, financial complications, dependent care, I don't think it's surprising to see those percolate to the top. And then just about 2% of these were completely elopement, and they really had absolutely no idea that the patient was gone until much later. So that certainly can occur as well. When we're thinking about this topic, we might want to consider what the current guidelines are and recommendations around this. And there's nothing that exists. There's no organized body that's published any kind of standards, and that includes the Joint Commission. So it really does create a dearth of knowledge about this, and has created extremely variable practice patterns among physicians. I often consider this as part of the hidden curriculum. We often see a more senior physician doing this during residency, and we tend to emulate what we saw there, not knowing that there's no good system in place for this. When I looked at my own neck of the woods to see what our rules and regs were in our hospital, this is really it. And to be honest with you, I would imagine this is probably pretty similar at many institutions for those who are on for this. You know, our rules and regs just comment that if someone's going to insist on leaving the hospital AMA, that we make a notation of the incident and we have the patient sign one of the standard release forms, if you will, one sentence. And again, there's no formal policy around this. Basically, the nurse will print out this one-page form. They'll have the patient sign it. They'll try to have a witness sign it, and that goes into the chart. And that's often all that there is to this process. And I would argue that this is not a really robust method to use. And hopefully we can flesh out maybe some better sense of where we should head with this. Now, I had mentioned that there's no formal definition of the AMA discharge, but I did pull from the literature, I guess, one definition, and I felt like this really resonated with me. So I will latch on to this one. And I think there's 4 key elements to this definition. One, that it's triggered by the insistence of the patient. 2, that it occurs prior to the medically indicated workup or treatment or management or discharge planning. Number 3, and an important part of this is that this can't be safely transitioned to the outpatient setting. Maybe that's the case, maybe it's not the case. And then 4, and I think this is a very important element that we need to weave into our documentation, is that the patient has decision-making capacity. So I like this definition because I think each of these 4 individual elements are really important and will help us with how we tackle these processes in our own institutions. Now, looking a little bit more at the background for the AMA discharges, there's a laundry list here of diagnoses and issues that are more prone to be associated with an AMA discharge. Those of African-American descent, those with HIV, homelessness, mental illness, substance use disorders, just Medicaid insurance across the board, younger age, male sex, low socioeconomic status, and then a few chronic illnesses as far as asthma and cirrhosis they carve out as well. And just having a prior history of leaving AMA discharge, if you will, of course, is a risk factor as well. So I think when we look at this list, we can see that, disproportionately, this does affect vulnerable populations. So yet another reason that we really need to have a system and try to handle these kinds of discharges in a thoughtful way. Now, patients will routinely report feeling stigmatized when they're going through this process. And I don't think it's a stretch to see that. Many patients will report that they have a reduced willingness to follow up for care afterwards if they have to go through this process. And one study even found a quarter of patients that were discharged AMA from the ED did not want to return for any follow-up care. And that is, of course, unfortunate. We know that this can label a patient, and this gets carried forward in the chart and can interact with their future interactions with the healthcare system. And because of all of these, we really need to have a little more holistic way to address these AMA discharges so we can provide the best patient care that we can. And, we need to acknowledge the fact, quite frankly, that there can be some overwhelming extenuating circumstances that may influence someone's decision to leave AMA. And I think this list is probably going to resonate with a lot of people here. And really at the top of the list for me is this limited care options for their dependents, right? If I've got a parent who needs to be home to take care of the kids, that can be a hard stop from a discharge standpoint. But work obligations, we know some individuals, when they start a new job, you will have a 6-month period of time where they can't miss one day of work or their job might be in jeopardy. You can just imagine the amount of stress that causes an individual. Wait times for care, of course, can be an issue. Communication is always something that we need to worry about that could promote this. Being in a teaching hospital setting, which I know most of us are, right? The medical student does their evaluation, the resident does their evaluation, maybe there's a senior resident that then goes in, and then the faculty or attending comes in, and that can be exhausting for patients. Substance use or withdrawal, and that easily would include tobacco, alcohol, as well as other substances. And again, I'm sure there are many other reasons, but these are probably some of the key ones that would percolate to the top that could be competing reasons that a patient needs to leave before everything is said and done. Clinicians, I think physicians have, again, sort of been acculturated part of this hidden curriculum to believe that, yep, when there's an AMA discharge, our only responsibility is to have this form signed, and then we're sort of done. There's no other responsibility that we have here. This is all sort of on the patient. It's their fault, if you will. And I would argue that that's certainly not patient-centered care. And the reason for the hidden curriculum is the fact that, again, most of us have not had any formal training around this process whatsoever. So again, we just tend to emulate what we might have seen in the past. And I think myths will certainly then start to occur in this kind of a setting. And remember, I'm certainly not going to get to the conclusion of this lecture and say that every AMA discharge can be prevented. I know that is not the case, but I do think there's a percentage that could be prevented. And even if that's one a year that we gain from this, I think that can be a powerful part of the process. So just a summary of this epidemiology around the AMA discharge. So to highlight, yes, no formal education is typically done on this topic. No formal definition even exists for this. It's somewhat common. 1 to 2% of hospital discharges can see this occur. A third of these cases really have no robust documentation around what occurred. And often there's, or a fifth of the time, there's factors that we may be able to modify that could help promote and prevent someone from leaving AMA. Remember, there's no standards, there's no guidelines around this. It disproportionately affects the vulnerable populations. And of course, stigmatization and conflict, I would argue, and hope most would agree, is not something that we want to introduce into the physician-patient relationship. So with that background at our feet, let's turn our attention now to these 5 specific myths of the AMA discharge. And we're going to take each one of these individually. But the first one is hearkening back to these questions I put up at the beginning. And that is, when a patient declines to remain in the hospital, we must discharge them AMA. That we have to use the discharge forms and that this is beneficial to this process is myth number 2. Myth number 3 is that using these AMA forms specifically will absolve us of legal liability. The fourth one is that we really are not obligated to do any of the other typical discharge services if we're doing an AMA discharge, arranging follow-up, making sure that there's medication refills or some sort of treatment plan. And then the last myth is that patients will be liable for their hospital bill to a larger degree if it's deemed to be an AMA discharge. So let's tackle each of these. The first, again, when a patient declines to stay, we must discharge them AMA. And I think it's important to sort of reframe this. This decision to leave AMA is, quite frankly, very similar to any other medical decision that a patient may make. And they certainly have the right to decline this, whether we agree with it or not. Just as when I'm recommending a medication, a patient may decline because they have competing values or interests, and we let them do that. I think when I think of it in this light, it makes a little bit more sense to me. I think it is important that we review the risks and benefits of this decision, just like we would with any other medical decision. And this should be well documented, right? We should outline this process in the chart. But beyond that, there is no official obligation to label any discharge as AMA. Like I said, there's no guideline, there's no requirement for this. We'll talk a little bit about institutional requirements, but remember, those are sort of homegrown. Those are not national or state level requirements by any means. And again, with there being no real consensus, that adds to the difficulty with these, again, about what even constitutes an AMA discharge. And of course, these can be confrontational, stigmatizing. We want to avoid that. And although I may still do an AMA discharge, I really am trying to reserve it for those really just freakishly extenuating circumstances where there's really just no other alternative, if you will. And again, we'll go through this in a little bit more detail. Myth number 2, the use of these specific AMA discharge forms from our institution is beneficial to patients and physicians. And you know where we're headed. No, there's nothing specific about these forms that help with this process or make it a high quality process. Really, these forms are typically just requiring a patient signature and a witness and not much more than that. I would argue that it's our high quality documentation in the chart that means a whole lot more to this process as opposed to this form. So remember, there's no evidence of any kind of established benefit from using that specific form. And quite the opposite, this can really introduce strife into a situation where we're trying to actually have the best trust and most open communication that we can have with the patient. So again, these aren't evidence-based. They've not been shown to inform the consent discussion around this. And it can really take this process and make it very legalistic, which I would argue, again, is not going to make for a very positive experience on both parties' standpoint, patient and physician. And again, competent patients have the right to decline this. We just need to make sure we have informed consent around this. And again, the forms do not necessarily provide benefit. And just having them have the signature on this does not necessarily gain us anything. And we can see where this would introduce distrust in the process. The patients are going to feel that our motives for around this, signing this form, are more at decreasing our liability or punitive from the patient standpoint. So again, this common theme of how challenging the use of these forms may be and actually may work against us. Now, the third myth is also related to these standard forms, and that the use of these will absolve us of legal liability. If a patient leaves AMA and there's a horrible outcome, we are not going to be held liable or accountable for that decision. And that's absolutely a misconception. And there's no evidence that these forms alone provide any superior liability protection. Quite frankly, the liability is lower when we follow the typical tenets of a discharge. And that's reviewing this process with the patient, doing shared decision-making, using harm reduction approaches, and making sure that we're clearly documenting what's occurring around this discharge, as opposed to just using this one-page AMA discharge form that many facilities will have. And when they have looked at this from the literature standpoint, they've really shown that this designation of AMA discharge does not confer liability protection. So we know we've got this evidence to help us in that regard. And again, it's the proper execution of the discharge process that makes a big difference here. And we may even argue that, quite frankly, our legal liability is larger if we use these forms, right? The patient can definitely have the perception of feeling deserted or devalued. And I would argue that those are circumstances that will make a patient consider filing a legal complaint, if you will. So again, these may actually work against us in that regard. So I think that's important to remember. There's no legal liability relief from this. There's no get out of jail free card by using these forms. The fourth myth: physicians aren't obligated to provide other treatments and services at discharge. And there are many times where I've had a nurse call me and say they're discharging this patient, they wanted to leave AMA, they had him sign the form, we are done. We don't need to send over medications or do anything else. And really trying to reframe this and reminding them that we want to do the best we can and try to at least deviate to some sort of treatment that we can attempt as an outpatient, or at least make sure that there's medicine refills and follow-up that's being undertaken. So we should try to design that treatment plan, even if they're leaving, sort of against our recommendation, if you will. So I think that's going to be an important part of this process too. And then the final myth, which we've even got some evidence is probably the most common myth, is that patients will be liable for their hospital bill if they leave AMA. And I cannot possibly tell you the number of times that I've heard this from every individual in the hospital. And they have looked at this in the literature as well. One study looking at 450 AMA discharges found that there were no payment due to that was denied because of an AMA discharge status. So no, this is not accurate. However, when they have surveyed physicians, 70% of residents, almost half of attendings, believe that this myth is in fact accurate. And there's also a similar amount, 85% of trainees and 2/3 of attending physicians will actually impart this information inaccurately to a patient, saying, hey, beware, you're going to be likely receiving a larger bill for this hospital discharge that's being labeled as AMA. And using this, of course, it can easily be seen as coercive and undermine this physician-patient relationship. So at the very least, do not further this myth, at the very least, if nothing else, out of this lecture. So again, not rocket science, but I think all of us have probably heard these during our career. And just to recap, these myths, again, when a patient is deciding to leave AMA, we must label it as an AMA discharge. Not necessarily. The use of these forms is beneficial to the process or absolves us of legal liability for myth 2 and 3. No, that's not the case either. And that we're not obligated to do a normal discharge or try to arrange follow-up or treatments if someone leaves AMA. This too, I would argue, is a myth. And then again, this last myth, this increase in financial responsibility, And we can rest assured that that is not accurate, and we should try not to perpetuate that. So those were the 5 myths, but I do want to go through a few other general points that don't necessarily fall within that bucket of the 5 myths. I know this is repetitive, but bear with me. We just want to make sure we bring these points home. And that's with regards to alternatives here. Again, this is a medical decision not unlike any other, and it's going to be important to put reasonable alternatives on the table. And we're going to have to use our judgment about what's going to be appropriate for a discharge or not, what's going to make us stretch here a little bit more to do this as a normal discharge, for lack of a better word. But I do recognize that there are going to be times that this is just over the top. It is not safe. It's not even something we can condone. Yes, I may use an AMA discharge in that standpoint, but of course, still going to do robust documentation, still going to do robust treatment and a discharge process whenever possible for that. And remember, these aren't any different than any other healthcare decision that we might make with a patient for a medication or a test or some other treatment. We want to use that concept of shared decision-making, of course, is going to be a part of this, and we want to take into account their preferences and values. In some ways, I think a lot of this is similar to when I'm addressing substance use disorder with a patient as well. We want to try to avoid the patient versus physician mentality that can sometimes occur with these. I know I myself have found these all very anxiety-provoking very early in my career, and these did become very antagonistic. And I think it's important that we try to check ourselves and try to prevent that aspect, even if there's no other choice but to use an AMA discharge. And again, this is just reiterating those themes that we've talked about: shared decision-making for this process, harm reduction, or meeting the patient where they're at, and trying to do the right care for the right patient at the right time. So again, repetitive, we just want to make sure those themes are driven home, if you will. So we've gone through the background or the epidemiology of the AMA discharge. We've talked about those 5 myths of the AMA discharge. We'll loop back to them again near the end. Let's switch gears and turn our attention to just some models that we can use with our trainees to help them tackle these complex issues. These two are not rocket science by any means, but I have found it useful to pass this on to residents or medical students just so they have a framework on how to address this. And so let's start with the ask, tell, ask model first, and then we're going to go through what's been put out as some universal precautions to try to prevent an AMA discharge. The first one is more to how to tackle it if it's occurring. The second one is more preventive. So ask, tell, ask method, not rocket science. It's really having robust communication with the patient, trying to find out what their thought process or knowledge is for why they're in the hospital, trying to fill in gaps in their understanding, inviting them to share in this decision process. And then if they are still deciding that they're leaving AMA, making sure that this is consistent with their stated goals, their preferences. And if we are doing this discharge, trying to use standard discharge procedures. So again, as I mentioned, not rocket science. This is very simple, but at least it gives a little bit of a framework for what our residents or medical students can do when they're tackling this. Let's move to preventive measures that we might be able to consider around AMA discharges. And that's the Against Medical Advice Universal Precautions model. This has been put out in the literature. And I like this, the 4 elements that are related to this. And we're going to hit each of these individually in a little bit more detail. But to call these out, the first is treating substance withdrawal and pain appropriately. These are complex issues, even in the best of circumstances. But it's important to address that. Communication is number 2. And of course, we want to be compassionate and non-judgmental in this communication. We want to proactively manage bothersome physical and emotional symptoms that may decrease the risk of an AMA discharge. And utilizing psychiatric consultation early may be something we can do to prevent a discharge AMA. And let's break each of these down individually. And I think most of us are going to be aware of this, but I think I'm highlighting this when I'm thinking about the possibility of an AMA discharge. And that's making sure that we're aggressively treating substance withdrawal. And again, that can certainly include nicotine as well. uncontrolled pain, for instance, needs to be addressed if we're going to have hope of keeping this patient here in the hospital and doing what we need to do. It's felt that just by addressing this aspect, if you will, appropriately, that we may be able to cut AMA discharges in half. So that's the reason this is really listed as number one. And of course, we all know that those who are on chronic opioids may face some stigmatization. Providers may not be aware that they do need higher doses during a true acute pain event, if you will. And when I think of this, the anecdote that I have around this is I was coming on the service, fortunate enough to have a fantastic resident team with me at our residency, and we were getting ready to admit a patient from the ED, a very unfortunate young woman with a cancer diagnosis. But when we're previewing her chart in advance, she had left AMA 3 or 4 times over the preceding 3 or 4 months. So the team really decided to tackle this right out of the gate as far as what went on with these prior AMA discharges. And unfortunately, there was not a lot of robust documentation around this. Come to find, this was an individual who is still smoking tobacco. She had been desperately trying to cut down. She was embarrassed with her cancer diagnosis, if you will, and this had become a huge source of tension for her. She felt that nicotine patches did not do this for her at all, and still felt that she needed to have a cigarette on occasion. And unfortunately, during her hospitalizations, she was often tethered to an IV pump. These aren't things that can just be wheeled outside the hospital without nursing presence, for instance, and always met a lot of resistance to going out of the hospital to have a cigarette once or twice a day. So you can see where we're headed with this. Once we knew what was going on, we tried to address this with her directly. Of course, I wasn't happy that she was still smoking, but recognized that she put a lot of effort to it, and tried to negotiate with her, the team, and definitely involve nursing to make sure that we came up with a schedule for her so that she could go out with her IV pump and have 1 cigarette a couple of times a day. Of course, it was essential to involve nursing. We didn't want this during change of shift, for instance, when time is at a premium. So we do like to think that by being very proactively addressing this, even though it might not have been what we had hoped for originally, we'd like to think we did some benefit here in having the patient stay for the appropriate duration for what they needed to be. And again, this was just something as simple or complex, if you will, as a tobacco withdrawal. So that's my standard anecdote with regards to this. And I think that leads into number 2, which is communication. And of course, that theme of compassionate and non-judgmental is really what we tried to weave into this case. But we know many studies have shown that a large percentage of those that are leaving AMA have even given some sort of shot off the bow that they might be considering leaving AMA. And we take this very seriously. And if we hear this, we try to stop in our tracks and make sure we address this very early on. We don't ignore this to try to address it in the moment, if you will. And I know that investment of time, at least for me, anecdotally, will often pay off, if you will. I think most of us, when we're communicating, have that theme of under-promising and over-delivering. I think this lab will be back in 2 days, but my real hope is it'll be back in 1 day. But I think, again, setting expectations for patients can be very helpful. We may know inherently something's going to take 3 days to come back. They may think it's going to be back in an hour. So I think trying to setting the stage for these timelines of issues when available can be very helpful. The next, number 3, is proactively managing bothersome physical and emotional symptoms. Patients don't feel that these are being addressed. We know that this can increase their risk for leaving AMA, unfortunately. So yes, things like nausea, anxiety, insomnia, trying to tackle these proactively have been shown to decrease that risk from an AMA discharge. So we want to make sure we acknowledge and alleviate these concerns whenever we can. And a lot of these that percolate to the top are probably things that we should be trying to do anyway for most of our patients. Sometimes it's just as simple as limiting overnight vital signs so that someone can get a good night's sleep. Sometimes it's orchestrating a room change. Maybe it's being farther away from the nursing station, so it's a little bit quieter. Limiting blood draws, quite frankly, we probably overdo it from a blood work standpoint anyway, and it could be very good to home in on this and try to decrease it, especially if it's not helping us and becoming a barrier to care. And I'm sure there's other changes that we could throw in there as well. Then the fourth one is this possibility of using psychiatric consultation early. And I know everyone's shop or institution may be different in what they have available. I guess my main theme with this is I'm not trying to get my psychiatry colleagues involved in the midst of an AMA discharge. That's almost too little, too late. However, if I do have a patient with a number of psychiatric issues, and I do have concerns that this may be around the corner, it might be more appropriate to sound out my colleagues and involve them earlier as opposed to in the last minute when there's a crisis. And I've certainly seen residents who have done this. This patient with some psychiatric issues is attempting to leave AMA. Let's put in for a stat consult to psych. And I don't think that that's typically very advantageous, at least in that scenario. But in other scenarios with some forethought, I think it could pay off. So those were just some of the things with regards to these universal precautions. I'm going to go off on another tangent here and just review, I guess, just a formal way to structure responding to these AMA discharges. And I've got a wonderful little diagram here. We're not going to go through and parcel out all of this, but I will sometimes pull this out for my learners so that they have a script to follow and consider. And really, this is just highlighting all the things that we've talked about, right? If somebody is able to make decisions and wants to consider a discharge, we may allow them to do it and follow a normal process, is really sort of what the loop is with this. But again, it makes it a little bit more concrete for residents and medical students to have some of this. So of course, stole this from the literature, and we'll use this on the floors just so we've got an outline of how to handle this, especially when it's the learner's first time for doing it. Other parts to this process when I'm considering an AMA discharge is trying to elicit trusted supports. Often that's a spouse or a child, for instance. And again, not using that in a coercive fashion, but making sure that they're enlisted in this process and trying to help when it's appropriate. I do try to make sure I assess for a patient's decision-making capacity. Quite frankly, this could be a whole separate lecture in and of itself. The vast majority of our patients probably do, in fact, possess this. And if I've got questions or I'm not certain, then I may need to phone a friend, get neuropsych involved, or other individuals to help me out with this process. But I would argue for most, this is usually cut and dry, but I want to document that. I'll consider not using this AMA form, and I will consider doing all the normal elements of a discharge, even if it's being labeled as AMA. So with that being said, let's turn our attention to documentation. And this is really just a brief review, quite frankly, of all the things we've already talked about, but I just wanted to have it on one slide to highlight it. And really, for this robust documentation, we want to avoid these scenarios that occur in a third of the time where there's no documentation whatsoever, right? Certainly a travesty. We want to make sure that we record the events that are leading up to this. We want to make sure we're using fact-based information and not emotionally laden language. And I would argue that being involved in some of these, it can become very antagonistic. It can become very emotional. I think it's very important that we stop ourselves and take a break before we consider that aspect of things. We want to try to be collaborative with our decision-making. We want to outline the patient's rationale, right? If they had to leave because there's young children at home and there's no other option, I think that's important to review here. We want to at least make sure that we're taking into account their capacity and documenting that. We're making sure that we prescribe medications when appropriate, even if it's not ideal. We want to do the best we can. And we want to try to make sure that we have specific follow-up in place and return instructions in place, just like we do with any other discharge, even if this is being labeled AMA. So this too, I think, is at a very bare minimum, something we can really easily do and add around this process. Now, just to make sure we know that this isn't as easy as we might think, there's going to be a fly in the ointment, and that's around Medicare's hospital readmission program that was introduced in 2012. We know that hospitals are dinged financially if someone comes back to the hospital too early or readmitted too early, if you will. And that program does have language set up where if a patient is discharged AMA, it limits the CMS readmission penalties in particular. So our institutions may push us a little bit more to utilize these forms. And I certainly want to be a good steward to my institution, but at the same time, I want to make sure I'm advocating around this process. And again, I would still argue that it may not be appropriate to label each and every discharge as AMA, for instance. I think there's some flexibility we may have in this. So I'm certainly not going to say I've got all the answers for this. I at least want to raise awareness around this topic. And it's something we have to weigh in and factor when we're dealing with these AMA discharges. So hang in there. We've gone through the bulk of the talk. I want to just highlight a couple of very stark examples about AMA discharges or the potential not using of an AMA discharge. And again, we'll often use this with the learners. For one example, patient with an acute NSTEMI, their chest pains resolved just after a couple of hours, and now requesting immediate discharge. And I think many of us would agree that this would be a very challenging discharge to do just after a couple of hours at this point. This may, in fact, be stretching credulity. I may really, in fact, label this as an AMA discharge, and I may, in fact, pull out the form for the patient to sign. However, I'm still using shared decision-making. I'm still being non-judgmental. I'm still trying to arrange for follow-up. I'm following an orderly standard discharge process, if you will. So I'm still doing those elements, even though I'm labeling this as an AMA discharge. So I think that's one aspect or one example. The other factor here, the other side of the coin, is a very different scenario. This is a stable immunocompetent patient with moderate cellulitis in the lower extremity. They've already had 12 hours of IV antibiotics. They've had minimal improvement. And I think most of us would feel better if we had another 24 hours under our belt. But again, the patient may have an intervening need to leave. Maybe it is going to be, in fact, okay to consider the possibility of transitioning to oral antibiotics, making sure we go through an orderly discharge if there's good reason for this, trying to make sure that there's appropriate follow-up, I think could be the case. And we may not need to label this as AMA. We may not need to pull out any kind of institutional forms around this. Do I want my documentation to be robust around this? Absolutely. Explaining what the thought process was and why we were making this shared decision with the patient, if you will. So again, documentation is going to be essential here. And we'll even go through some of the language that's been promoted in some of the articles I'm going to mention here. And I think it's important for the residents to hear this on occasion, just to know what they're going to do in the moment. And just, yeah, we're recommending that you stay hospitalized. We think it's going to keep you healthy and safe, but I recognize you have competing priorities. Let's work together to come up with a plan. Again, I think just making sure that the residents realize that this is an acceptable conversation can be very helpful here for the process. So we're nearing the end here. We've gone through the epidemiology around AMA discharges. We've talked about those 5 common myths, a couple of models to use if we're in the moment of one, an as to last model, these universal precautions that may be preventive in nature, making sure we have robust documentation around an AMA discharge, I think is going to be essential. And then we've given our 2 extremes, if you will, from an example standpoint. So to summarize, from a final recommendation standpoint, these are probably the key things that I would say here. And that's one, treating all discharges similarly. You know, this isn't, I've heard the patient's leaving AMA, I'm done, I'm not, contributing to the process anymore, I think is a tragedy. We should avoid that. I do think I'm a little bit more judicious of when I'm labeling a discharge as AMA. Like I said, it's not that I expect that we're not going to do this at any point in time, but again, I'm trying to be very thoughtful and considering around this process. I do make sure I'm at least rudimentarily assessing capacity. Usually it's pretty obvious, but I'm making sure that I weave that into my documentation. And I'm going over the reasons for why the patient's making this choice and talking about how I am making maybe some possible different recommendations based on that. And again, even if this does become an AMA discharge, I'm still trying to collaborate with the patient, do a standardized discharge process, and still trying to make sure that I'm arranging for robust follow-up, even if it may not be what I agree with from the patient's standpoint. I think they have that autonomy to make this clinical decision. And remember, in no way, shape, or form am I promoting a cookie cutter process. I know that each and every single one of these AMA or potential AMA discharges will not be alike. But I have to tell you, having some of this framework in mind when I tackle these has really been very reassuring for me. I'm much more curious and calm about this and have a system for how I tackle this. And quite frankly, I think it's been better for my well-being to have this. So I would argue at the very least, we may come away with some personal positives around this. And I'm hoping that you'll you'll think about some of these aspects if you're faced or when you're faced with the next AMA discharge or possible AMA discharge. And as we wrap up, of course, we're going back to those 5 questions, which were the 5 myths one last time. Do we have to label an AMA discharge as AMA, if you will? We don't have to. Do we have to use these discharge forms provided by our institution? Again, there's no mandate that we have to do this, and they certainly do not decrease our legal liability. There's no get out of jail free card. And remember, we still are obligated to follow other practices of a normal discharge. And we should certainly stop promulgating this myth that patients will have a higher financial outlay for an admission that's designated as AMA, if you will. So please remember those myths and use those liberally with your learners. As we look at some of these waterfront views for my hometown in Erie, and one of our beach views in particular for delightful sunset, just makes me think of some of these guiding principles for AMA discharge that, quite frankly, are guiding principles for all of our care of patients, right? Empathy, calm, curious, non-judgmental, shared decision-making, harm reduction. I think if we tackle it with these few things in mind, we won't go wrong, if you will. And I did want to conclude with regards to some of the references that I've got here, and I know that these will be available in the handout. Really, the primary author I would put for this is Alfondre, an article in the Annals of Internal Medicine and also one in the Journal of Hospital Medicine. Quite frankly, if you do those 2 articles, you will be up to speed on this topic. And of course, I liberally took the information from those articles to structure this lecture, but would really encourage looking at those for a little bit of a deeper dive into this subject. And I've got my contact information up here in case anyone ever wants to reach out. And what I'll do is I'm done at this point, and what I'll do is I'm going to turn it over to Dr. Conti, but if she agrees, I'm just going to run through some of the questions that I see that have come through the chat, if that's okay first, and then we'll sort of look to where else we head here. And let's see here for ones that I can answer.
So before you get to those questions,
ahead,
Dr. Bolkowski, thank you so much for this informative and engaging lecture. And yes, there are some questions in the chat already. Feel free for other participants to either put your questions in the chat or raise your hand, and we as a panel can highlight you and get you to call on you for those questions. So go ahead, Dr. Bolkowski.
Yeah, I think there were just some comments about slides, and I know that those are going to be posted, of course. Let me just glance at some of these others here. Oh, someone just commenting that with the stigma attached with AMA, that they're using terms such as patient-directed discharge. I actually have not heard of that. I think that's a wonderful way to advocate for our patients, if you will. And words have power, and I think that's not a small thing. I'm seeing some institutions where they've utilized, it looks like foster pets or things to help out with this process, maybe from an avoidance of an AMA discharge. Again, if you've got those resources, I think it's great to bring those to bear. That's not something that I've seen or heard of in the past, but very delightful to see.
That was a comment to a question that was actually in the chat for you, Dr. Bolkowski. Is the person just asked, they have a significant number of patients that want to leave AMA because of pets, animals, dependents.
Okay.
And just asked, has anyone else been seeing more of that? Because even more than caring for a child or for a parent, it's the caring for the pet or animal that causes them to want to leave. Any thoughts about that?
It's and I'm sorry, I think I'm reading through these backwards, so missed the original thread with that. But I would say anecdotally, I've definitely had those experiences, and I know sometimes we need to make sure we check with the team, because I know sometimes my junior colleagues have been a little bit more dismissive of that. And we know that that is not the case, right? These are important members of the family. And I think it's just the exact same process sometimes as having a young child at home. So I don't know that it has anything else unique. I would say that it's it's important and we need to take it into consideration and we need to address it. Sometimes it's working with the patient to see if there's somebody else we can reach out to or contact for them to watch a pet or take care of a pet. We're sort of lucky to have residents and medical students that can sort of take some of these things on. And although they may not be overtly medical, I would argue that in that scenario, it's going to be probably more important than anything else that we address. So I wouldn't have any other specific plan attack other than trying to, again, follow those general principles that we've talked about already.
Great. I don't see any other questions in the chat, so folks can feel free to raise their hand and so we can get you off of mute. I do have a question and a comment. So thank you for being so thorough. And I had all kinds of topics down and you addressed all of them. One is around the readmissions that you brought up. There was a push for us as providers when the recommendation for some of our more frail patients to go to a skilled nursing facility prior to going home. And when in cases that they refuse to do so, to have them as AMA discharges. And this led to lots of debate about the ethical manner of that. So just wanted to hear your thoughts. Have you heard that? How do you approach that?
Yeah, and I'm not going to say that I have all the answers by any means. I feel there's several layers that I would put out for this. One is making sure that physicians are part of this process and addressing it in the institutions, that we can advocate for our patients and promote what we think are going to be safe, empathetic, caring decisions, I think is certainly one aspect. I think the other practical aspect is I may still use an AMA discharge form because I know it will help from, say, the CMS readmission penalties. But beyond that, I'm really just trying to have this robust, curious conversation with my patients. So making sure I team with them, recognizing that although they might be making a decision that I disagree with, that I'm still here for them and here to promote to do the best that I can, even though I know it may end in failure, recognizing that it's an important decision for them to make. I'm certainly trying to assess capacity. Oftentimes I'm thinking of these scenarios being elderly individuals. Sometimes there are denser cognitive deficits, overt dementia issues that we need to take into account. If I'm recognizing that early on in my institution, I can rely on neuropsychiatry to help us out with that process if I'm not certain about their capacity. So those might be some of the elements that I try to weave in. But again, not that there's a cookie cutter approach. Those would be just some of the things I'd be mulling over. Does that make sense, Dr. Conti?
Yes, absolutely. Thank you for that answer. Do we have any other questions from the audience? Well, seeing none in the chat, and I don't see anyone highlighted, Dr. Polkowski, again, I want to thank you so much on behalf of the FMEC for presenting this to our members and for the resources that you are providing. Such an informative and timely discussion. So thank you.
Thanks, Dr. Conti. Thanks so much for allowing me to participate. And thanks, of course, to Scott and Denise as well. Hope everybody has a good rest of the afternoon.